Okay. All right, are you seeing my full slides?
Yes, we are.
Okay, great. Sounds good. All righty. Get started here. So good afternoon, and thank you so much for the introduction and the opportunity to join today. My name is Alyssa, and I am going to be discussing trends in the epidemiology of extended spectrum beta-lactamase producing Enterobacterales, or ESBL, in Boulder County, Colorado from 2020 to 2022. And I was invited to speak here today by Deborah Heineman, who works on our team for the surveillance project. So a little intro about myself. I think we covered it for the most part, but I'm a current epidemiology PhD candidate with the University of Colorado. And I do serve as a research assistant at the Colorado Department of Public Health and Environment, Healthcare-Associated Infections and Antimicrobial Resistance Program. I will be completing my dissertation through a collaboration between CDPHE and the Colorado School of Public Health. I've served in my role as a research assistant for a little over 2 years, and prior to this, I received my MPH from the Colorado School of Public Health in 2018 and worked for 3 years as a fellow at the CDC Division of Vector-Borne Diseases in Fort Collins. So I'll start with a brief background on antimicrobial resistance and our surveillance for ESBL infections in Boulder County. So some of you may know, one important group of bacteria are known as Enterobacterales, formerly Enterobacteriaceae. Enterobacterales are a large order of gram-negative bacteria that can be a normal part of the human digestive tract. Examples in the Enterobacterales order include E. coli and Klebsiella pneumoniae. However, there are over 70 different species in this group. These bacteria can cause foodborne, community, and healthcare-associated infections. They can be spread from one person to another in healthcare settings through contaminated hands and surfaces. Enterobacterales can produce enzymes called extended spectrum beta-lactamases, or ESBLs. And these enzymes break down and destroy beta-lactam antibiotics, including penicillins and cephalosporins, and make these drugs ineffective for treating infections. These enzymes produced by the bacteria degrade the beta-lactam ring, which you can see in red in this illustration, to render the antibiotic ineffective. This type of resistance mechanism is commonly passed on mobile genetic elements that spread quite easily among bacteria. Many times, these types of infections need to be treated with carbapenems, considered a last line of antibiotic therapy. In many cases, even common infections such as urinary tract infections caused by ESBL-producing bacteria require more complex treatments. So instead of taking oral antibiotics at home, patients with these infections might require hospitalization and intravenous carbapenem antibiotics. These infections can occur in people with exposure to healthcare, such as long lengths of stay and repeated hospitalizations that would include hospitals, as well as nursing homes, long-term care facilities, and long-term acute care hospitals. Some other risk factors for infection include travel to places with high endemicity. So ESBL-producing infections have been identified in people returning to the US after traveling abroad, especially to places where these bacteria are more commonly found. Other risk factors include previous antibiotic therapy, invasive devices or procedures, such as ventilators, urinary catheters, or intravenous catheters, and underlying comorbidities. So we know that chronic conditions put people at higher risk for infection. These conditions and some medicines used to treat them can weaken the immune system. So patients who receive dialysis treatment have a higher risk of infections, and people receiving chemotherapy are often at risk for developing infection during treatment. Overall, antibiotic resistance disproportionately impacts the most medically vulnerable. So the young, elderly, and sick, people who commonly receive medical care. Often the most deadly resistant bacteria spread from patient to patient across healthcare facilities through patient transfers. However, ESBL-producing Enterobacterales can also cause infections in otherwise healthy people who have not recently been in healthcare settings. So in healthy people in the community, this often means urinary tract infections. So a little bit about our surveillance for ESBL producing infections. The Colorado Department of Public Health and Environment and Boulder County Public Health conduct population-based surveillance for ESBL infections in Boulder County. And this program in Boulder County began with a pilot in mid-2019. The program is funded and supported by the Centers for Disease Control and Prevention Emerging Infections Program and is called the Multi-Site Gram-Negative Surveillance Initiative, or MUGSI for short. So there's a link here that you can learn more about the MUGSI program. We do surveillance for more than just ESBL. We also do surveillance for carbapenem-resistant organisms, such as CRE, carbapenem-resistant Acinetobacter baumannii, and Pseudomonas aeruginosa. So the surveillance objectives of this program are to evaluate the incidence of these resistant gram-negative bacteria and to describe changes in incidence over time, to characterize the epidemiologic characteristics and risk factors associated with these infections, and to describe resistance mechanisms and strain types. So data from the surveillance will ultimately help shape prevention strategies to contain and prevent the spread of resistant bacteria. So again, this is part of the Emerging Infections Program, or EIP. So you can see the other states that participate in this program with us. So these states also conduct the MUGSI surveillance within their unique catchment areas in their state. So here's the case definition for how we identify ESBL infections. We define these as extended spectrum cephalosporin resistant E. coli or any of these Klebsiella species isolated from normally sterile sites or urine from a resident of the surveillance area, which would be Boulder County. And normally sterile sites include things like blood, CSF, peritoneal fluid, joint fluid, bone, or other sources where we just wouldn't expect to find the bacteria. Resistance is defined as resistance to at least one extended spectrum cephalosporin, so those listed here, and non-resistant, so susceptible or intermediate to all carbapenems tested. So ESBL is a laboratory reportable condition in Boulder County, and cases are identified based on the local clinical lab's antibiotic susceptibility testing data. So most local clinical laboratories conduct antibiotic testing using automated testing strategies. And many of the clinical laboratories within the surveillance catchment area identify specimen results meeting this MUGSI case definition directly from their susceptibility testing. So a little bit about our MUGSI chart review. So once we identify cases, we then do manual chart review, which is conducted by trained epidemiologists on our team. So the previous year of medical history for case patients is reviewed either through healthcare system portals such as Epic or paper charts that have been requested by healthcare facilities. And the first extended spectrum cephalosporin resistant Enterobacterales of each species per patient in a 30-day period is eligible for inclusion as an incident case. So if a specimen was collected less than 30 days after a patient's last incident case of the same organism, that would be categorized as non-incident and a case report form would not be completed. So data are then captured and entered onto the CDC case report form. So we collect patient demographic characteristics, location of specimen collection, types of infections associated with their positive specimen, underlying medical conditions, and healthcare exposures. And here's just a snapshot of what the case report form looks like. It's a 4-page form though, so this is just a snapshot of the first page of the case report form that we fill out. So for this specific project, we described trends over time in the epidemiological and clinical characteristics of ESBL cases from 2020 through 2022 through an analysis of our MUGSI surveillance data in Colorado. So I'll talk a little bit about that. So for this analysis, we considered all incident cases that met the MUGSI case definition between January 1st of 2020 and the end of 2022. All identifiers were removed prior to analysis, and we performed descriptive analyses and chi-square tests for trends using our software. And for categorical comparisons with small sample size, we use Fisher's exact tests. Note that estimates from 2022 were preliminary at the time of the analysis. And while all ESBL cases were included for case counts and calculation of incidence rates, only cases with complete case report forms were included in the further epidemiological analysis. So you'll note that we had a total of a little over 1,000 cases, but only 881 had complete case report forms that were retained for our analyses. So into some of the results that we found. So from 2020 to 2022, we saw that there were increasing counts and rates. So first, we did see that we had a total of 1,036 ESBL cases. And again, those increased across years. You can see the respective frequencies here by year. And rates per 10,000 population increased from years across years as well, which you can see noted in this third bullet point, that how the rates were increasing. So incidence rates were calculated using the Colorado State Demography Office estimates for the county population size. And our population denominator data for 2022 were preliminary. But the incidence rates really take into consideration the population growth of Boulder County across time. A little bit about the demographic characteristics of our cases. Overall, cases were predominantly female, and this trend remained consistent across all years of data collection. Most cases were non-Hispanic and white. However, you'll note that about 14% of cases were considered unknown for race and about 18% unknown for ethnicity. And the mean age of cases was about 60 years, with a range from less than 1 to 97 years of age. About 70% of cases had at least one underlying condition present. The most common underlying conditions across all years included chronic pulmonary disease, diabetes, and cardiovascular disease. We saw that the proportion of cases with at least one underlying condition increased significantly across our years, from about 60% in 2020 to about 70% in 2022. We also noted that about 5% of cases had urinary tract abnormalities, which we have a unique definition with our MUGSI surveillance program for how we identify what those abnormalities might be. These can include things such as chronic incontinence, bladder prolapse, neurogenic bladder, things like that. Most specimens were collected from outpatient settings, about 92%, which did not significantly change across years. Outpatient specimens were predominantly collected from clinics or doctors' offices. Across all years, the majority of isolates were identified as E. coli, so about 90% were identified as E. coli for the organism. But here you can see the breakdown of the different organisms that were noted, as well as by year, and then their total. So after E. coli, the most common being Klebsiella pneumoniae. The proportion of cases due to urinary tract infections increased significantly across years. So we had about 84% in 2020 to 89% in 2022. And overall, urinary tract infections were most commonly associated with these cultures. So in this graph here that combines all of the years together, you can see overall UTIs being the most common infection type. You can also see other types of infections in this chart. We had 70 cases of bacteremia, which remained consistent across years. Similarly, pyelonephritis was noted for 62 patients and remained consistent across years as well. Other types of infections were less commonly reported and included septic shock and others such as peritonitis, abscesses, decubitus ulcers, cellulitis, and pneumonia, and also osteomyelitis. Overall, patient colonization was uncommonly noted, so only about 1%, which remained consistent across years. And evidence of recurrent urinary tract infections were recorded for about 30% of cases across all years, and that remained consistent. So some trends in the risk factors for ESBL infections are shown here. This is a section of our case report form that asks a lot about healthcare exposures, healthcare risk factors for these patients. Some things that we discussed before, such as hospitalization, this would be within the previous year of their incident specimen, as well as any stays in long-term care facilities or long-term acute care hospitals within the last year, and also any surgery within the previous year. You can also see other things that we look at, which would be urinary catheter use or indwelling devices, central lines, and dialysis. So overall, there were no significant differences in most of these risk factors across years, as you can see with the differences in color denoting the different years. However, presence of a urinary catheter prior to infection, which would be 2 days before or the day of their specimen, did significantly decrease across time, from about 34% to about 17%. So we saw overall that significantly decline. The most common risk factor was any hospitalization in the prior year. So among patients that had any risk factors at all for these ESBL infections, about half had a previous hospitalization in the year before their date of their incident specimen collection, which remained consistent across years. There we go. So we also looked at exposure to antibiotics. So on the case report form, we do ask about, or we record any information in the medical chart that would denote patient exposure to antibiotics within the previous month. So from 2020 to 2022, previous antibiotic use in the 30 days before the date of their specimen collection was documented for about 30% of cases. And the most commonly reported antibiotics included third and first generation cephalosporins, penicillins, nitrofuran, and fluoroquinolones. And we also summarized what information that we did have on antibiotic susceptibility testing. So we saw that isolates, their susceptibility to piperacillin tazobactam remained consistent across years. You can see the percentage here susceptible to each antibiotic. So that top one being for piperacillin tazobactam specifically, and the percentages by year. Susceptibility to gentamicin generally decreased across years, again with the percentages shown. And this trend was also seen for tobramycin and tetracyclines. There was a slight increase in susceptibility to trimethoprim sulfamethoxazole in 2022. And that was just from a crude sort of look at our results for the susceptibility testing that we had access to. So again, this is limited by the data that we had access to from the medical record, and not all testing is uniform across labs or done for all antibiotics. And then this is just the last result slide here for our case patient outcomes. So there were 163 patients hospitalized on the day of or in the 29 days after their specimen collection, so about 19%. And there were 36 patients admitted to an intensive care unit on the day of or the week after their incident specimen collection, so about 4%. We also saw there were 6 case patient deaths with incident specimens collected in 2020. And of these, all had at least one underlying condition. So this is for 2020, and we're still working on the outcomes for 2021 and 2022. All right, so a little bit of discussion points. So the main findings from this project were that ESBL counts and rates increased from 2020 through 2022 in Boulder County. Urinary tract infections were most commonly associated with cultures, which significantly increased by year. The presence of a urinary catheter on the date of incident specimen collection or the previous 2 days decreased across years. We saw decreasing trends in susceptibility to some antibiotics that were noted, such as aminoglycosides and tetracycline, among the isolates with AST or antibiotic susceptibility testing results in the medical record. And overall, some of this evidence really points towards spread in the community. So about 92% of isolates were collected in outpatient settings, which were overwhelmingly urinary tract infections. And about half of ESBL patients had no traditional healthcare risk factors that would sort of explain their infections, things that we looked at for that chart about our risk factors. So about half of patients did not have any risk factors or traditional healthcare risk factors. Some limitations, data are subject to laboratory reporting practices and may underestimate cases. And medical records may not contain all patient health history or risk factors, such as patient travel or long-term care facility exposure. We also know that 2020, of course, had probably a large impact on this surveillance and the information you're able to collect, such as case identification, data collection, data entry and cleaning, and isolate collection and submission. And this was across all EIP sites. In some cases, medical record review could not be completed, and there might be a percentage. We expect that the percentage of cases for which information is unknown is higher than in previous years for 2020. We will note that that is one limitation. Something to consider is that we have seen ESBL in general increasing nationwide and far sort of looking further back than 2020. So we do expect that isn't necessarily the reason sort of why we see this increase. Generally, we've seen ESBLs increasing overall. And just some conclusions. So nationwide increases in antibiotic-resistant infections are also occurring in community healthcare settings in Colorado. And strategies to combat antibiotic resistance should also target ESBL-producing infections. So some takeaways from this analysis also that I've thought about is just really more research is needed to understand how ESBL is spreading in the community and unique risk factors among these patients without traditional healthcare exposures. One study from 2019 noted that patients in the community, some unique risk factors included indwelling urinary catheter use, which would be sort of in an outpatient or sort of outside of the healthcare setting, history of recurrent UTIs or recent antimicrobial use as risk factors for sort of an incident ESBL infection in the community, but really more work is needed on this topic. So better understanding of sources of and risk factors for acquisition in the community is necessary to inform public health measures that reduce the incidence of infections caused by ESBL. And also one thing to note is that we'd like to replicate these findings at other EIP sites as well. So I like to end on prevention. So this is a nice schematic of just prevention of antimicrobial resistant infections in general. So not just ESBL. But things to note when we think about ESBL is keeping hands clean is one of the most important steps to avoid getting sick and spreading the bacteria that cause these infections. ESBL producing bacteria live in the GI tract, so it's especially important to clean hands after using the bathroom and before eating or preparing food. You should remind healthcare providers and other caregivers to clean their hands before they care for you and before they handle any medical devices as well. Currently, few community-based strategies to decrease ESBL incidence in the United States have proven effective. However, improving antibiotic use in the outpatient setting, especially for the treatment of urinary tract infections, where E. coli is the most common cause, might help to reduce selective pressure for ESBL. So we know that antibiotic stewardship could play a role in reducing the risk of resistance, not only in the individual, but also on the population level. So a huge thank you to our MUGSI team, both at CDPHE and Boulder County Public Health, who work on the surveillance project and do many chart reviews for this surveillance project. And also a thank you to the Colorado School of Public Health, my advisor, Dr. Abraham. And I'm happy to take questions, and here's my email as well for contact information. But thanks.
Thank you, Alyssa. Does anybody have any questions for her?
Yeah, hey, Alyssa. I'm Matt Mittiga. I'm the medical director at CU Boulder. Um, if you said this already, I apologize, I missed it, but I was just curious from the Boulder County data, do you have any idea of, if we have a positive culture for E. coli, but we don't have the sensitivities back, kind of what the pretest probability is, that it's an ESBL producing E. coli?
Yeah, no, that's a good question. I don't know that off the top of my head, and I can also maybe defer some questions to my team here. One thing to note with our case definition is we really rely on a phenotypic case definition. So we're not doing that genetic testing for the actual production of the beta lactamases. So we have looked at the pretest probability, or we have looked at the positive predictive value of the phenotypic case definition that we rely on, which I believe was 80 or 90% the results there for how well it was at detecting a true specimen that's producing these beta lactamases. But we're not just relying on this sort of the AST results for our case definition. I don't know for your question, sort of without the AST results, if we just have an E. coli, what we would expect. I don't know if Jen or others want to jump in if they have thoughts on that.
Hi, this is Jennifer Driscoll. I can kind of comment a little bit. Most hospital laboratories will produce what's called an antibiogram. And so they will look at all E. coli's that they have tested throughout a year or a certain time frame that they may report this, and produce a table of common antibiotics and what the percentage of susceptibility is to those through that region. So that's something that you could reach out to the specific hospital laboratory where you may be wanting to find that information, and they would be able to give that to you.
Oh, thank you.
Yeah, hi, Bob Belknap. I'm the Chief Medical Officer for Boulder County Public Health and also an ID doc at Denver Health. I was actually going to comment on the same thing. I've just pulled up our antibiogram at Denver Health. My experience has been that the pretest probability for it being an ESBL is pretty low. And just looking at our own antibiogram, which is isolates from 2022, almost 3,500, 92% were sensitive to ceftriaxone. So that's usually a pretty good indicator. If it's an ESBL, it'll flag as resistant to that. And so that doesn't mean that 8% were ESBLs. It just means that was, that's the maximum margin you could have potentially for it. So I don't know the statewide data, but again, I think it's relatively low. You can predict to some degree who might be at increased risk if it's someone who's been on repeated courses of antibiotics as an outpatient, been hospitalized or on dialysis, as was mentioned. You start adding in multiple factors. If someone has a number of those things, then the likelihood of an ESBL goes up. And then I'd say clinically, that determines that, and how sick a person is will determine if you should empirically go with a carbapenem or something more broad with treatment. So thanks for the presentation. It was fantastic. A couple of questions. One was, you mentioned that there were 6 deaths, and I wondered if those were you able to determine if the deaths were due to the ESBL infection, or just it was a death and they happened to have the ESBL, were in that cohort?
Yeah, I believe it's the latter, that we are not able to definitively say if it is the infection. We go back and do mortality matching with vital statistics. We go back and kind of do that with our cases retrospectively. I have to pull up our full case report form to see exactly how we ask about, when we're filling it out, how we ask about mortality, but I believe it's the latter, that these are just patient deaths that we don't know for certain. Mm-hmm.
Okay, great, thanks. Is there any genotyping done when you talk about understanding community spread and some of the dynamics of that? Are isolates genotyped to kind of understand the patterns, or how much similarity or differences there are among these different isolates?
Yeah, no, that's a great question. So we do send a sub-sample, or essentially a limited number of isolates to CDC, so that they do additional, genotyping. That's all done at CDC, and then they are able to do that in-depth analysis and look at sort of those questions. So there's a publication from the pilot done in 2019 that talks a little bit more about the genotyping done on these isolates that are submitted by states. Again, for kind of a subsample of our total cases. So that's all done by CDC to look at that.
Great, thanks. Then my last sort of thought or comment on this was around the point you made that a lot of this appears to be people acquiring the infection in the communities, and so thinking about how might we target strategy for that. And I think it is probably reflective in part of the challenges with antibiotic stewardship in an outpatient setting when you've got providers who are, largely unmonitored as it relates to that, and have balancing the appropriate level of autonomy for someone who is providing medical care, but also educating around the overuse of antibiotics. And we know this to be true for all kinds of things, right? Urinary tract infections, a big one for ESBLs, but infections for sore throats and upper respiratory infection, all sorts of other things. All of this drives the likelihood of more resistant organisms being in the community, and how to approach that. It's easier in a hospital setting. It's a requirement from Joint Commission that hospitals have to have an antibiotic stewardship program now. That's relatively new. I don't know when that became true broadly, but certainly within the last 10 to 15 years. But it seems like the next big step is how do we really get this into the community? Because education alone doesn't work. You have to have some metrics that you can measure and provide feedback, I think, to people to really get folks to change behavior. So that's a comment, not a question. But thanks so much.
Yeah, thank you. No, I agree, it's a challenge, and we'll be looking at exposure to antibiotics for part of my dissertation, but have limited it to inpatient hospitalization because outpatient is just so tricky. It's so difficult to measure, and adherence and things like that. I did pull up our case report form just so I didn't get the wording wrong, but we essentially record for the mortality question. We record sort of the patient outcome if they survived, died, or unknown, and that would be at the time of the chart review. So this is the initial go at it. And then we also collect date of death, and then on the day of or in the 6 calendar days before death was the pathogen of interest isolated from a site that meets the case definition. So we do record that in a binary fashion. And again, we go back and retrospectively also record mortality for patients after the chart review is done.
Yeah, thanks. That's helpful. It can be really hard to determine did someone die with or because of. People who are really sick are more likely to get colonized, and you may identify it. It may not be a proximate cause, or the contrary. It could be that someone is incredibly sick because of the ESBL, and that leads to their death. So I think I realize the nuance of that is challenging too. So thanks.
Well, if there are no other questions, I want to thank Alyssa for presenting today. And this was recorded, and it will go out to our members after this presentation. So thank you. Let me turn off the recording.